All right, welcome to today's session and the discussion of today. We are going to look at thyroid and anti-thyroid drugs. And I'm Dale Benyumiza, a pharmacologist. So to start with, to know where the thyroid hormones that we are going to discuss are being secreted, and anatomically they are secreted by the thyroid gland, which lies over the trachea just below the larynx, and this thyroid gland basically consists of two lobes connected by a thin strip called the isthmus. So this is what we are talking about as the thyroid gland. It's just below the larynx and it has a butterfly shape. So this thyroid gland consists of two types of endocrine secretory cells, where we have the follicular cells and also the C cells. So the follicular cells, which are responsible to produce the iodide-containing hormones, the T4 and the T3 hormones, which we are going to discuss in details as we go on with the discussion of this presentation. And these collectively, these T3 and T4 are known as the thyroid hormones, which we are going to focus on. Then the C cells basically synthesize a calcium regulating hormone known as calcitonin. So this still shows an illustration. So I think this was cut from, so basically from here, this illustration, this is one lobe and another lobe of the thyroid gland. Then this is what we call the isthmus. So it has a butterfly shape. Here, this is the same. So there is a link in how the thyroid gland works in conjunction with the brain. So we call it the brain thyroid link. So the thyroid gland, basically we have seen that it releases the hormones which govern uh, growth, growth and metabolism. So this is very important, as we shall realize that most of the symptoms we realize due to dysregulations in these two, the metabolism and the growth. So you need to acquaint yourself early with these two common terms of sin. So the brain basically, where we have the pituitary gland, we shall see its role where it will be producing the thyrotropin releasing hormone. And the thyrotropin hormone will be released by the hypothalamus, where then its effect will be exerted on the pituitary, where we shall see the tissue releasing the thyrotropin thyroid stimulating hormone. So we shall see how all this works in conjunction up to the end of where we have our hormones, the T4 and T3 come into play. So basically, let's look at the synthesis of our hormones. That's the T4 and the T3. So most steps of the thyroid hormone synthesis take place on a large thyroglobulin molecule within the colloid. So we shall realize in the follicular cell, as we saw in our illustration here, we shall see in the first step, as you eat food, we expect that food to contain the iodide ions or iodide molecules. So these iodide molecules are taken up by the active transport. So here we have the thyrotropin controls the synthesis of this carrier. So we shall have here our iodide ion being taken into via this is the iodide sodium symporter into the thyroglobulin, the cell inside of the cell, and inside the cell. So this iodide ion um, will be deiodated to form iodine. So here we have seen that iodine is transported as iodide form from blood. So you have eaten your food which had iodine, so it will enter into blood saturation following the absorption of lactase and so on. So via the sodium importer, which I've talked about. We shall have iodide being entering into the thyroid follicular cell. So the iodide will then be the iodated form iodine. Uh, so 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 the iodine which is formed will then be there's a process what we call organification. So in organification, basically it's characterized by this enzyme, the thyroperoxidase, other basically abbreviated as TPO. So TPO will have remember we had the thyroglobulin in the here. So the thyroglobulin basically is like a reservoir, a large, a large protein where these hormones are being stored. So basically in this thyroglobulin, we shall find it has residues which we call the tyrosines residues. So our iodine, which was formed here, that process we call it organification to combine with the tyrosines to form the diiodotyrosine and the monoiodotyrosine. So these precursors, so these are the main precursors of T4 and T3, the monoiodotyrosine and the diiodotyrosine. So there is another process which we call coupling. So remember, we formed our precursors from the combination of iodine and the tyrosines using the thyroglobulin. So what we call coupling here, we shall have the meat, the monoiodotyrosine coupling with the diiodotyrosine to produce 3. So mono is 1 and the di is 2. So in cases of coupling of the mono and the di, they will give us a T3 um, hormone. Then in cases where there is coupling of two diiodotyrosines, we shall have T4 hormone being produced. So thyroid hormone is secreted by follicular cells and phagocytizing a piece of colloid, and a free T4 and T3 will enter the bloodstream. So basically the drawing was a bit smaller, that's why I've not really focused to elaborate more on the process through it. So where we have reached, we are at this level. We have, I remember I said that the thyroglobulin is where these hormones are basically stored. So if we have the release, we have seen the meat and so on, we shall have the release of the T4 and the T3 hormone into blood or plasma. So in summary, we have seen the iodide, maybe that iodide being transported by the sodium iodide importer. Then we have seen the iodination to form iodine. Then we have seen iodine, a process called organification combining with the tyrosine residues in the thyroglobulin characterized by the enzyme, the TPO, thyroid peroxidase enzyme, to form the MINT, monoiodotyrosine, and the iodotyrosine. Then we have seen coupling of the MIT and DIT to form T3. Then also there's coupling of the two DIT to produce T4. Then we shall see release of the T4 and T3 by phagocytosis. So our drugs basically will inhibit those processes. First, we shall have the anion inhibitors, which will act on the sodium iodide importer. Then we shall have other drugs like the thiourines or thioamides, which will act on TPO. Then also we shall have drugs which will act on also coupling still the thiourines. Then also we shall have drugs acting on the secretion and also in the plasma, the periphery, where we shall also have other drugs, as we shall see as we go on. So basically, regulation of the thyroid hormone levels. Thyroid hormone secretion is regulated by the negative feedback system between the hypothalamic, where we have the release of the thyrotropin releasing hormone, then also the anterior pituitary gland, where we shall have the release of the thyrotropin thyroid stimulating hormone, and also the thyroid gland, which will give us T3 and T4 as we have seen in the synthesis. So basically what we saw was taking place in the thyroid gland. So the feedback loop, maintain the thyroid hormone levels at a relatively constant level. So let's look at some of the factors which could trigger the hypothalamus to release the thyrotropin releasing hormone. So in cases we have cold, trauma, stress, we shall see that the hypothalamus will release the thyrotropin releasing hormone. So this thyrotropin hormone will act on the is sending a positive feedback to the anterior pituitary gland. So in the anterior pituitary gland, we shall have a release of the TCH, the thyroid stimulating hormone, which also will act on the thyroid gland to release our hormones. And when these hormones are released, the funny thing for them that again they cause a negative feedback. They will inhibit this process of the thyroid stimulating hormone, so we shall have a decrease in the release of thyroid stimulating hormone from the anterior pituitary. So we shall have our drugs here, the iodides, as I've already said, coming to acting on the thyroid, as we have seen in the synthesis, the theourines or thioamides, then also iodide salts and iodine, then also radioactive iodine coming into play to inhibit the thyroid release. So the iodides have both the positive and the negative, but the duration by which the two occur matters, as we shall see in our discussions. So the hormones, the T4 is basically the tetraiodothyronine, also known as the thyroxine. Then the T3 is triiodothyronine. So still we have the chemical structure. So you can see we have the R3 iodine molecules, 1, 2, and that's giving us the T4. So the naming basically is dependent on the number of the iodine molecules. Then we have tri, we have 3, 1, 2, 3. Then we have the reverse. So the reverse here, you see the differences between the benzene ring, which is close to the skeleton, the carbon skeleton. So here we see that the number, here we have iodine at the 50th position, but here the iodine is on a different, on the second benzene link. So, and basically this one is inactive, the reverse T3 hormone. So basically, this still summarizes what we saw in the other illustration of the thyroid follicular cell. We have iodide iron being transported through the iodine transport iodine pump. It enters the thyroid gland or follicular cell. Uh, will have enzyme peroxidase to get iodine. Then the iodine combines with the thyroglobulin residues, which I call the tyrosines, to give us the monoiodotyrosine and diiodotyrosine. Then we shall have a coupling of the MET and DIT to form T3. Then with the coupling of 2 DIT, we form T4. Then also we shall have proteolysis, that's rupture, and that is into blood. So we also have other drugs which are acting on the peripheral thyroid hormone. So still this is the same. Maybe to acquaint you with this, we can talk about the drugs. These are the anions which are acting on the transport, the pump, the iodide pump. So this is thiocyanate, then this is perchlorate. Then here we have the peroxidase enzyme, the TPO. We have drugs also acting to block that process. We have the iodides and the thioamides or the thiourines. Then we have proteolysis um, to form, remember there was coupling, then to release these hormones into blood. The iodides would come into play. Then in the peripheral tissues where we have already our hormones into blood, we shall have also drugs, the ipodate, the beta blockers, as basically here I can give an example of propranolol, which will prevent the conversion of T4 to T3, but also they play other roles in management of other side effects of hyperthyroidism. Then we also have corticosteroids coming into play. So let's look at the normal actions of the thyroid hormone. So required for normal fetal growth, development, and maintenance of all body tissues. Remember, in the start I said these hormones control growth and metabolism. So in case where there is absence of the thyroid hormone in early life, it will result in irreversible mental retardation, which is known as cretinism in infants. So here we have decreased small brain actually. The brain will be underdeveloped. So then also in the adults where there is the absence of thyroid hormone, we shall have this condition myxedema, which we shall see how it presents the symptoms of this condition in adults. Then also these hormones exert cryogenic actions. Remember I talked about metabolism, so they increase heat production also as well as increasing the basal metabolic rate. Then also these hormones have an effect on the sympathetic nervous system where there is overactivity in case of hyperthyroidism. So if there is excess, we expect to have sensitiveness, increased sensitiveness, shaking, increased nervousness, irritability, and rapid heartbeat, because these hormones have an effect on the sympathetic nervous system. So, thyroid disease. So, basically, these are diseases affecting the thyroid gland, and this thyroid gland is the one which is producing the T4 and the T3 hormones. So, millions of people in the world, especially in the US, have the thyroid disease, and most of them are women. I would beg you to go and look out as wise women. Then, if you have a thyroid disease, your body uses energy more slowly or quicker than it should. So, in these cases, we are talking at elevated levels of the hormone and also the decreased levels of these hormones. So, if your thyroid is too active, it makes more thyroid hormones than your body needs, and that condition is known as hypothyroidism. So, too much thyroid hormone can make you lose weight, speed up your heart rate, and make you very sensitive to heat. Then also in cases where the thyroid gland is not active enough, in the process is called hypothyroidism, so it cannot produce enough hormones. So it's far more common, and it can. So here in these cases, there is weight gain. You feel fatigued because the metabolism rate has decreased, and you no longer have enough energy. And then weight gain still because your body cannot use the food you are taking into, so the fats will keep piling up and to the mass and the muscles will keep what building up and you gain weight. And also in this case with hypothyroidism, you have a difficulty with dealing with cold temperatures. Remember there is a decreased metabolic rate, so less heat is being generated to cope up with the cold temperatures. So we have already looked at this where we have too much secretion, that's hyperthyroidism. Then where there is little secretion, that's hypothyroidism. So thyroid gland and the thyroid. So in hypothyroidism, we have already seen a rise in body temperature, sweating. Remember, there is a lot of hormone, and we say the hormones are these hormones are increasing the basal metabolic rate and also increasing the metabolism. Then weight loss, which is now the opposite, the other side. So here the body will break down all the muscles. So basically the person will be emaciated, trying to cope up with uh, the, 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 the needs of the metabolisms, which are our hormones are triggering. Then rise in blood pressure. So then also irritability. So persons with hypothyroidism most likely present with these signs and symptoms. Then in hypothyroidism, the opposite will occur in adults. Then in the infants, there is decreased brain and bone growth, cretinism. This, what we call cretinism in infants, occurs due to low thyroid hormones. Then goiter occurs in both, though in hypo it's known as simple goiter. Then in hyperthyroidism is known as toxic goiter, where the gland is overactive and is producing a lot of hormones in hyperthyroidism. So this is what occurs, these illustrated diagrams here, images in hypothyroidism. Remember, weight loss, you can see the person is a bit slim, the eye, tobacco, then the thyromegaly, the gland is trying to enlarge. Then in hypo is like someone who is inactive. So a person is weight gain, whatever you eat is not broken down faster. The face becomes perfect, like somehow in the width, you can compare the width of this person and the other compared. So the person the face becomes a bit more deformed with hypo. So let's dig into our pharmacology. Remember, the basic lecture is on pharmacology, though we had to understand the physiology behind, and then we bring in our drugs. So we have seen in hypothyroidism there is decreased thyroid hormone production. So basically the management here is to do hormonal replacement. So we can give hormones to replace the hormone needs in this case. So we have the levothyroxine, which is T4, and the thyroid hormones, basically the two hormones used in the management of hypothyroidism, where in cases we have low thyroid hormones. Then in hyperthyroidism, so here we're trying to bring the hormones, the T4 and T3 into normal. So we shall use drugs basically which are aimed at reducing the hormone secretion. We have the thioamides or the thiourines. An example is the propylthiouracil. Then we have iodide. We have the Lugol solution. Basically, this is a combination of iodide salts and either potassium salt. Then we have the beta blockers. Example I gave propranolol. So this was acting in the periphery. It was blocking the conversion of T4 to T3, but also it has other these beta blockers, they have other effects on the heart. Remember, we saw in hypothyroidism there was increased heart rate, so they could have another benefit. Then we have the radioactive iodide. So let's start with hypothyroidism, where we have seen the connection with thyroid gland fails to produce enough thyroid hormone. So here the rates of metabolism slows, causing mental and physical sluggishness. And the most severe form of hypothyroidism in adults is myoectoderma, which is a medical emergency. So in hypothyroidism, the thyroid gland can be small or large depending on the cause of low levels of thyroid hormone. So this is how basically your patient or your client will present like. So complication, untreated hypothyroidism can lead to a number of health problems. We have seen goiter, heart problems, mental health issues, myxedema, birth defects, which we have already discussed in our physiology. So basically in myxedema, occurring in adult, in the infants it was cretinism, where there is decreased brain development and bone growth. That's in the infants. But in myxedema, we're basically focusing on adults. So you hear the hair, the texture of the hair will be dry, coarse, and also sparse. Then also the lateral eyeballs will become thin. Basically, also most important feature to note would be there will be periorbital edema. Then the face will also become perfect dark face with a dry skin. So treatment, we already talked about the thyroid hormones from our tree. So here we are doing a lot of hormone replacement. So we have the levothyroxine, the T4 can be given in grams of 70 to 100. Then the liothyronine T3 per day. Then there is this Riotrix, which is um, Riotrix. Also, then there is hormone replacement in terms of ratios T4 to T3 of ratio of 1 to 2. But remember, T4 is always converted back to T3, which is the active form. Then also there's what we call the skated thyroid hormones. So these are marketed, also they have their marketed names. Uh, the Cytomo, the Thyora, Ama, and so on. So basically here we're doing hormonal replacement therapy in cases of hypothyroidism. So we have already seen, so the therapeutic uses of the hormones, we have seen they're applicable in hypothyroidism. So hypothyroidism is usually treated by oral administration of levothyroxine, 75 to 200 micrograms daily. Then also so another thing to note that when they say hypothyroidism, it does not mean to immediately manifest as myxedema or cretinism. So other things could cause a reduction in our hormones, in the thyroid hormones. So another therapeutic application could be the myxedema, where we have adult hypothyroidism. Then we have cretinism. So basically here treatment with thyroid hormone promotes normal physical and mental growth in the infants. And it is essential that the treatment should be started during the first 6 weeks of life. So this is an important aspect to be noted. So every good thing has a bad side. So the adverse reactions with hormonal therapy. We have nervousness, hypertension. Remember, these hormones, as we saw in hyperthyroidism, they were stimulating this. So as you're trying to manage, you may again over cause hyperthyroidism. Shortness of breast, vomiting, diarrhea, increased sensitivity to heat, impaired reproductive function. So you may result again hyperthyroidism, especially in adults. So these are the adverse effects of managing with hormones. Yes, we are pressing hormones, but also remember where you're putting these hormones are piling up. So in the end, we may have effects of hyperthyroidism coming into play. So basically, this image just shows you how the person may present like a person is told to keep watching. So a person keep who is on watch, or is the eyes may protrude out. Then let's look at hyperthyroidism. So alternative names, we have thyrotoxicosis, which is a medical emergency, then also overactive thyroid. So most likely people may use these terms to refer to hyperthyroidism. So in hyperthyroidism, we have seen that there's a caused by an overactive thyroid gland, and the gland makes too much T4 and T3 hormones. So the excess of the hormones may be caused by tumors of the thyroid gland or area of the pituitary or ovaries, then also inflammation of the thyroid or ingestion of excessive amounts of thyroid hormone or iodine. Then also there's what we call Graves' disease. So here there is an antibody. We shall see this basically that there is an antibody that is increasing the release of the thyroid hormones compared to the normal TSH, which was responsible for stimulating the thyroid gland to release our hormones. So those with increased thyroid hormone levels experience heat intolerance, increased energy, difficult sleeping, diarrhea, and anxiety. So you see this was the normal size of the thyroid gland, but in this case, the thyroid gland will enlarge. Remember, it's trying to cope up with the demand of the thyroid hormones. So remember, anything that is overworked most likely may hypertrophy. So it will enlarge and produce more of the thyroid hormones. So that's what we are calling goiter hyperfunctioning thyroid gland, enlargement of the thyroid gland. So complications, hyperthyroidism can lead to a number of complications where we have heart problems, brittle bones, eye problems. People with Graves' ophthalmopathy develop eye problems, including bulging, sensitivity to light, blurring, or double vision. Red and swollen skin. Then we have cytotoxic crisis. So this is a sudden intensification of the symptoms leading to a fever, rapid pulse, even delirium. If this occurs, seek immediate medical care. So you can see how bad having excess thyroid hormones is. Still, these are some of the symptoms. Sensitiveness. Remember, it had an effect on the empathetic nervous system, shaking, increased nervousness, rapid heartbeat, feeling hot. It also increases metabolism, so there will be a lot of heat generation, weight loss. In case there's no food in the GIT, it will result into muscle breakdown, fatigue, feeling exhausted, more frequent bowel movements, and so on. So let's look at the pharmacology. So drugs used in hyperthyroidism, we have the thiourines, also known as the thioamides. Then we have the radioiodide or radioactive iodine, then iodide and iodine. Then also the beta blockers. So basically the pharmacology here is to reduce thyroid T4 and T3 synthesis. So the thioamides or the thiourines, we have examples of drugs like propylthiouracil, also known as PTU, methimazole, carbimazole, and thiamazole, and their mechanism of action. So the major action is to prevent hormone synthesis by inhibiting the enzyme thyroid peroxidase characterized reactions. Remember we had I talked about the TPO, thyroid peroxidase enzyme. So basically these drugs will inhibit this TPO. So when they block this enzyme, they will block iodine organification, that binding of iodine with the thyroglobulin residues, the tyrosines, to form the monoiodotyrosines and the diiodotyrosines. So they also block this TPO activity of coupling of the iodotyrosines, the MIT and the DIT, to form the T3 and T4. However, this other drug, the PTU, propylthiouracil, can also prevent the conversion of T3 to T4. Remember, another drug I made mention of which was inhibiting this conversion was a beta blocker, basically propranolol. So, basically, these are the drugs which I've already seen. And then also, so these drugs have no effect on the thyroglobulin. Remember I said thyroglobulin was like a storage form of these T3 and T4. So in cases where the hormones have already been formed, don't expect immediate effects by these thioamides. For them, remember they are blocking the process, but already in this case, we have the hormones already being stored in the thyroglobulin, this large protein. So not until there is depletion of the hormones from the thyroglobulin, the effects of the thioamides will not come into play. So this implies that clinical effects of thioamides may take several weeks to show until the thyroglobulin stores are depleted. So what does this mean? This drug may not help with in cases where we need immediate effects, in terms of lowering the T3 and T4 from blood. So let's look at the therapeutic uses. Of course, hyperthyroidism, then also supplementary treatment of thyrotoxicosis. Remember, this was an immediate, needed immediate medical attention. It was an emergency. So as I said here, this drug has no effect on the immediate um, medical needs because it inhibits the processes of T3, T4 synthesis. But in cases where we have already the T3, T4 being formed and are stored in thyroglobulin, our drugs, these thioamides, their effects will come into play after there is depletion of the thyroglobulin stores, which are storing the T3 and T4. So here, when you use it as supplementally, of course, you may need another drug with immediate effect, like the iodides, the radioactive iodides, and then this thioamides may be used just as a supplementary in that case. Then also preparation for the thyroid surgery. So still you can administer these drugs, the thioamides, the propylthiouracil, the carbimazole, the thioamides, methimazole, and so on. So adverse effects of thioamides, we have skin rash, fever, enlargement of the lymph glands. Then we also have granulocytosis in about 0 to 3% of the patients. Though it's infrequent, but it's the most dangerous. Then we have hepatic abnormalities. Then also these drugs, the thioamides, can cause the placenta and cause fetal hypothyroidism. So basically, maybe to explain, to illustrate more on the fetal hypothyroidism. So this drug, remember, we are giving it to reduce the synthesis of the thyroid hormones. So in cases where it crosses the fetus, I mean the placenta, it will also have an effect on the fetal thyroid gland. That's why we shall end up having fetal hypothyroidism. Another class to look at is the iodide source and the iodine. Today they are rarely used as a sole therapy. So the usual forms of this drug are the Rugol solution. So basically this is a combination of iodine and potassium iodide and the saturated solution of potassium iodide. So the mechanism of action of these iodide salts and iodine. So large doses of the iodides have several actions on the thyroid, and these iodides will act by inhibiting organification and hormone release by inhibiting the TPO enzyme. Remember, TPO enzyme was in the first was it was deiodination to form iodine, then also organification. So basically, if there is a lot of these iodide salts, they will overwhelm the enzyme, and in the end, the enzyme will not do its due process of organification and also the coupling to produce or synthesize the hormones. So basically, that's how these iodide salts and iodine inhibit the enzyme. When there are many, of course, they will. I would refer calling. I would basically call it sweeping off the enzyme or blocking its activity, compared if there were the normal doses of iodine which the enzyme needs. So high concentrations of iodides inhibit hormone release, possibly through inhibition of thyroglobulin proteolysis. So remember here there were release of the T3 and T4. And then also these iodide salts and iodine, they decrease the size and vasculature of the hyperplastic gland. So basically they will decrease blood flow to the gland. And in this case, if there is decreased blood flow, we expect also a decrease in hormone synthesis and secretion. However, their onset occurs within 2 to 7 days. Therapeutic use of iodide salts and iodine, simple goiter. So you can see it can be used in simple goiter, where you are just replacing iodine. So it has two ways. In hypothyroidism, you can as well give iodine or iodide salts. But in cases of hypothyroidism, you can still use large doses of iodide salts. So it also can be used as adjunctive therapy with thioamides in thyrotoxic crisis. Then also as a follow-up therapy after radioactive iodine therapy in Graves' disease. Then also used in a preoperative preparation for thyroidectomy. However, there are limitations with use of these iodide salts and iodine in managing of hyperthyroidism. There is this paradoxical effect. So prolonged use of inorganic iodide can lead to escape from its initial inhibitory effects and can even trigger an increase in the thyroid hormone release, known as the Jod-Basedow effect. So there is no need to use these iodide salts for chronic management of hyperthyroidism. Remember, we said large doses, but with time, maybe the doses may decrease, and instead of inhibiting the TPO enzyme, they may be used as substrate for the TPO to synthesize more thyroid hormones. Yet remember, we're treating hyperthyroidism. I think we have already seen this. Adverse effect, we have a acneiform rash on the skin. So acne, I think you have seen those like those pimples, but extremely large. Swollen salivary glands, then the mucous membrane ulceration, and also conjunctivitis may occur with iodide salts. Then we have radioactive iodine. So most common treatment in developed countries like the US, where there is nuclear medicine, takes center stage. So in also limited setting, use of this radioactive iodine may be limited. So half-life, it has a half-life of about 8 days, and rapidly and efficiently trapped by the thyroid gland. So the dose of radioactive iodine is determined by the preliminary uptake test, and is also as well adjusted for complete or partial destruction of the thyroid with no injury to the adjacent tissue. So the radioactive iodine is absorbed and concentrated by the thyroid gland, and the radioactive isotopes of iodine include both the beta, which is the majority with 99%, and the gamma rays, which are only 1%. So radioiodine is trapped rapidly and efficiently by the thyroid and is incorporated into the colloid. So the colloid is like a reserve actually. So in the start, I think maybe I missed to talk about the colloid. So you see the thyroid follicular cell, the center, that's like the colloid. So the center also has the thyroglobulin, which is also a storage of the T3 and the T4 hormones. So the beta particles of the radioiodine destroy the parenchymal cells of the gland. The therapeutic use of radioactive iodine basically used in hypothyroidism. So it's used to treat hypothyroidism in old patients and patients with heart disease, or patients with severe thyrotoxicosis. So, however, its limited use is in pregnancy because it can easily cross the placenta and cause fetal hypothyroidism. Also, it's used in diagnosis of disorders of the thyroid function. Adverse effects, you can see still hypothyroidism, which occurs in about 80% of the patients. So, it should not be used in pregnancy. Contradicted during pregnancy, radioiodine should not be administered to pregnant women or nursing mothers because it can cross the placenta and can be as well excreted in breast milk. So you may be treating the mother who has the condition of hypothyroidism, but remember the drug will cross the placenta, also be expressed in milk, and also affect the fetal or the baby's thyroid gland, and which we are not intending to. To look on again, we have another class of drugs used in management of hyperthyroidism where we have the beta receptor blocking agents. So the beta receptor blocking agents such as propranolol are effective for tremor, anxiety, nervousness accompanied with hyperthyroidism. So we can see that this drug basically it's a beta blocker, and we know the receptors of the where the beta receptors are located. So it can be used to manage the symptoms of hyperthyroidism, but also in the periphery, we said this drug prevents the conversion of the T3 to the T4, I mean to T3 at doses greater than this. Remember, T3 is the most active hormone. So adverse effects, we have a cardiovascular system, heart failure, atrioventricular conduction blocking. So these are some of the side effects of the beta blockers. Bronchial asthma. Remember, we have the beta receptors there in the broncho tree. So they will increase secretion, and then we have the asthmatic crisis coming into play with use of the beta blockers. Then we have the anion inhibitors. So we have the thiocyanate and the perchlorate. So these block the uptake of iodide by the thyroid gland through competitive inhibition of the iodide transporter. Remember, iodide was negatively charged. So also these drugs are negatively charged. So they will compete with the iodide so in the end, little iodide ions will be transported into the thyroid follicular cell. So their effectiveness is unpredictable, and perchlorate is associated with aplastic anemia. So these drugs are rarely used clinically. So basically, these drugs have the thiocyanate and perchlorate, and we saw they broke the uptake of iodide. This takes us back to the first process of our synthesis, where iodide was crossing into the follicular cells, or the thyroid gland follicular cells. So they will block that process by inhibiting the entry of iodide ion into the cell. So in other treatments, besides the pharmacology, we have the thyroid surgery, where we have the procedure which is called thyroidectomy. So in cases where the patients cannot tolerate the anti-thyroid drugs and don't want to have radioactive iodine therapy, you may be a candidate for thyroid surgery. So we may opt for thyroid surgery, although this is an option in only a few cases. So you have tried the pharmacological process has failed, and also the radioactive iodine therapy has failed. We may go into operate the thyroid gland. So in a thyroidectomy, your doctor removes the most of your thyroid gland. And the risk of this surgery include damage of your vocal cord and also parathyroid gland. Four tiny glands located on the back of your thyroid gland that help control the level of calcium in your blood. Remember, we had the C cells which were responsible for the hormone regulating calcium, the calcitonin, and also the follicular cells in our thyroid gland. In addition, we need lifelong treatment with the hormones to supply your body. So when they remove your thyroid gland, which means the body will not be able, in position to make more thyroid hormones. So the patient may entirely depend on hormone supply to cover up the absence of the thyroid hormones being produced by the thyroid gland. So if your parathyroid glands are also removed, you will need medication to keep your blood calcium level normal. So you can see the challenges with the thyroid surgery. Autoregulation of the thyroid gland. So we have seen that the T gland regulates uptake of its iodide and its thyroid hormone synthesis by intrathyroidal mechanisms that are independent of the thyroid stimulating hormone. So these mechanisms are directly related to the levels of iodine in blood. So in cases where we have large doses of iodine, they inhibit iodide organification, which is known as Wolff-Chaikoff block. So here we shall have reduced, in this Wolff-Chaikoff block, we shall have reduced thyroid hormone synthesis. So in instances where there is this condition, the Hashimoto thyroiditis, so here the thyroid hormone synthesis is inhibited and it will result in hypothyroidism. So where there is Hashimoto thyroiditis, the gland will not be able to synthesize the hormones required by the body. So it will present as hypothyroidism. Then hyperthyroidism can result in loss of Wolff-Chaikoff block in susceptible individuals, e.g. in multinodular goiter. Then abnormal thyroid stimulation in cases of Graves' disease. So here the lymphocytes secrete thyroid stimulating receptor stimulating antibody. I think I made mention of this antibody. So basically this antibody will act in a similar way as the thyroid stimulating hormone to stimulate the thyroid gland to secrete more, synthesize and secrete more of the thyroid hormones. But its effects are overwhelming to the thyroid gland. So there will be an increased synthesis of thyroid hormones compared to the way the thyroid stimulating hormone would be stimulating the thyroid gland to synthesize thyroid hormones. And also the effects of this antibody are longer compared to the natural thyroid stimulating hormone on the thyroid gland. So signs of Graves' disease, bulging eyes, goiter, we have enlarged thyroid gland. So these are some of the images for people with the Graves' disease. Some of the signs which we have already seen, and basically that brings us to the end of our lecture today. It has been a 48-minute lecture. You can sit and watch with your textbook as you take note of the discussions which we have had. Otherwise, thank you so much.